Hi, everybody. Welcome to today's very special episode of the Dr. Keith Darrow podcast. Today, we have a very special guest. We have Paula Webster, who is actually coming to us live from the Hearing and Brain Centers down in St. George, Utah. Paula, thank you so much for being here.
Thank you for having me. It's a pleasure to be here.
No, absolutely. Look, I am honored to work with you, Paula. You have been in this field for a long time. And look, for those of you out there who work with tinnitus patients that are suffering through this, you have found yourself the right podcast, because we are working with truly an esteemed expert when it comes to helping patients reduce their experience of tinnitus, helping patients experience a better life despite having the ringing. So Paula, how did this come to be? I mean, look, the work you do is amazing. How did you get to where you are today?
You know, when I first started in the field, which was a little over 12 years ago, when I was brand new, I had a patient that came in that had a level 5 tinnitus, very catastrophic. It ruined their day every day. They couldn't work. They couldn't function. It was interfering with friends and family and relationships. And I felt bad that, I didn't know how to help him. And so I dove into learning about tinnitus, went to several classes about tinnitus and continuing education. I wanted to learn more so I could help this patient. So after that, it just became a passion to see the changes that it can make in people's lives when there are those higher levels of tinnitus. It was amazing. And to be a part of that, to help give them relief when they were previously told by so many out there that nothing can be done, get used to it. And it's like, there is something that can be done. And, every person experiencing tinnitus is going to have a different story, a different journey. And I love that, we can be a part of that. And
how many times a day, Paula, does somebody say to you, "Oh, my doctor said there's nothing that can be done for my tinnitus"?
I pretty much see it daily, if not daily, 3 times a week at least.
Sure.
Sure.
And how do you look? I have so many questions for you, but let's just start with that one, because that's really, I think the hardest thing about treating tinnitus is overcoming that objection. Because I swear, I don't have real data, but I would guess 9 in 10 patients with tinnitus will tell you, I've been told there's nothing that can be done about it. So let's just start there, because that throws a lot of hearing healthcare providers like a curveball that they strike out on. They don't know what to do.
Yeah, I think for so long, tinnitus was such a mystery. We didn't know what caused it. We didn't know, why it was so different from each patient. And I think that comes down to understanding our patient and our patient's needs. You may have 2 patients that have the exact same level of tinnitus, the exact same sound, but how their brain reacts to it and how they personally react to it would be completely differently. So I think definitely individualizing our patients and listening to what they have to say and taking in all that information from them and letting them know, yes, your brain is missing stimulation. We know that. And by giving the brain back that missing stimulation, by treating it medically, that automatically helps reduce it. But there's lots to overcome, personal emotions about it, how it's affected their life. All that comes into play. And, a lot of people will say, there's no need to measure, it's subjective. It is subjective, but it's subjective for that individual person. And knowing how they feel about it, how they react to it, plays a big key on how we treat them medically and counsel them.
All right. So I love that. And I think you really nailed that there, but I want to challenge you some more. Let's do a little role play, right? So, okay, I heard everything you just said, but my doctor, right? Are you saying he's wrong? Are you saying that they're misinformed? Because they told me there's nothing that can be done.
I wouldn't say they're wrong, because I think at one point the field would say, nothing can be done. But what we know from years of practice and being in the field, we've seen patients where their tinnitus has been reduced. And, the ones that are extremely lucky, they feel like it's completely gone. And you can say that there's no actual treatment, but we know that's different. FDA's come out and said, yeah, treating your hearing loss with medical treatment of using the proper technology, it can reduce tinnitus. Before, we weren't able to say that. I remember, most of the manufacturers didn't even come on board until 5-6 years ago. There was only one or two that even addressed tinnitus. Most people kind of run from tinnitus thinking, I don't want to deal with that. But the numbers of how many patients out there suffer from tinnitus, how many patients have hearing loss. Most our patients that we see every day have some kind of tinnitus. If not there every day, it's there occasionally.
Well, look, what I just heard you say, Paula, and I know I've said this to patients, is you're right. And your doctor's not wrong. There is no cure for tinnitus. Just like there is no cure for cancer, there is no cure for heart disease, there's no cure for the vast majority of chronic medical illnesses that we deal with in society. And tinnitus being one of those chronic medical illnesses or disorders, we can't cure it, but we sure as heck can treat it. In fact, and you were alluding to this, right? If you really dive into the research, the single most effective treatment comes with our services, comes with the technology we use. In fact, we've got about an 8 in 10 chance with each patient. Those are great odds, right? I mean, for anybody out there who's a gambler, I'm pretty sure you would bet on this, right? There's an 8 in 10 chance that you can effectively reduce your patient's experience of tinnitus. Now, those are the key words, though, right? It's the experience of tinnitus, not right. You can't tell somebody, I'm going to reduce the tinnitus, I'm going to make it go away, because that's false advertising. But can I help you live with it better? Can I make your day better, improve your life? Heck yeah.
Yeah, I like to use the word management, because it's learning how to manage your tinnitus on a daily basis, or when your tinnitus is, reacting a little bit stronger, learning how to manage it using the tools that we teach you and guide you through that. I like to use the word management.
Paula, you are a great soldier and you're a great student. And you have, the International Hearing Society would love you for saying the word management, because that is the word that is used. However, and look, we could absolutely agree to disagree. I believe we're treating it. We're treating it by managing it. I know we're like splitting hairs here, but I think it's really important that our patients understand what we're doing. I would say not just managing, we are treating it, right? I mean, look at somebody who breaks their hip, right? They go through an entire treatment program. Maybe they go through surgery. They go through months and months of rehabilitation. Like, yeah, I might not be able to get them to run a marathon again, but I'm also not just teaching them to manage it, right? Like, just deal with it. I'm not just going to get them, get them a new one of those fancy chairs that automatically brings them up their stairs. Like, no, I'm going to help you walk up those stairs. That is treatment. And I know that that's just sometimes we're just parsing words.
No, I would agree with you. We medically treat the symptoms and the hearing loss, the auditory nerve damage. I would agree on that. I think when I use manage, I'm talking about them personally, like their day-to-day learning how to manage it.
Now, that's great. That's great. Let me ask you, I want to know, because one of the most common questions I get is, tell me about the protocol. Tell me what you do, right? And I know you and I are pretty aligned with this. So tell me about your process when a patient comes in and says, yes, I have tinnitus. Talk me through that.
Yeah, when I find that they say that, I usually like to ask a couple of questions. One, how aware of their tinnitus they are and how much it annoys them. I like to separate those two out, because they may be, on a scale from 1 to 10, and number 10 as far as awareness, but then it may not bother them, where the annoyance part of it is just a one or a two.
Love that.
And by separating out those two, it just helps you know that patient more. And that comes to when we set up our treatment plan, how we want to talk to them. Because if it's both 10, that's a completely different patient that is annoyed by it than who isn't. And that's a whole different ballgame of counseling as far as that goes.
All right, perfect. So here's what I just heard you say. For those listening and taking notes, step one, qualify the tinnitus, right? So qualify at a superficial level. I think you would agree 1 to 10 is pretty superficial, but it's a great starting point, right? So we're going to qualify the patient's experience with tinnitus. Great. What's number 2? What's next on the list?
Depending on how they respond to that question, I'll have them fill out a tinnitus, handicap inventory. I know there's several out there that are good. I don't think one's superior over the other. There's a couple that I like. I like the Iowa and the THI. I personally, just because that's what I've done from the beginning and just
that's okay.
12 years of habit, I use the THI. And
hey, look, 12 years of habit and over 20 years of peer-reviewed research, there's nothing wrong with the THI. I like the, primary function index by Dr. Tyler. But again, I ain't going to fight you. And I think the THI is great. So, okay. So here's what I just heard. Step 1, qualify. Step 2, quantify the impact of the tinnitus on the patient, right? And I love this because, I hear too often, my patient says I have tinnitus and I do tinnitus matching. I match the volume, I match the frequency. Look, and I'm not even going to argue whether that's right or wrong, but that's not it, right? You've got to measure the human impact. So we're qualifying our patient's experience. Now we're going to actually quantify the experience. All right, what's next?
When I first have them fill that out, I ask them to, as they complete the questionnaire, think of their overall experience of tinnitus. And then when they come in for follow-up, I'm going to phrase that differently. I'll say, since you last saw me, answer these questions, how your tinnitus has been since you last saw me, because I don't want their overall experience. I want what has happened since I've last seen you this last week, the last 2 weeks. And I think it's really important to clarify that because you don't want the same questionnaire completed the same every time. It's going to be different because our goal is to see that tinnitus reduce. And, a lot of people say those questionnaires are subjective. And I would agree, they are subjective, but it's that patient opinion on their tinnitus, which that's who we're working with. We need to know
nobody said they weren't. Nobody said they weren't subjective, right? I mean, look, I wish I had an objective test which involved no patient involvement whatsoever. If I could somehow put a helmet on their head and I can measure the volume, the pitch, the level of annoyance, how it interacts with their limbic system, like dream world scenario, the patient would do nothing. But that's not real life, right? So we have to qualify subjectively how they deal with it, quantify subjectively how they deal with it. But I'm going to call you on this, Paula. You just jumped to the end, which is continue. No, it's good. I love it. I love that because you're passionate about tracking progress, right? That is something that, and I'm sure you've seen it too, is really lacking with hearing healthcare providers. Like a lot of people ask the question, do you have tinnitus? And then they do nothing about it. Some people ask the qualifiers on a scale of 1 to 10. How is it impacting you? How loud is it? How much is it annoying you? But then a lot of people stop. You've gone to the next level of now I'm going to quantify it using one of these evidence-based surveys to determine how it's impacting your life. And now I'm going to track the progress of your treatment outcome, and I'm going to measure it again at the follow-up appointment, 6 month, 1 year, so I can actually say, did I do something for you, right? Did I actively reduce your tinnitus, or did I just ask about it on day 1 and then ignore it, which, is what most people do, because I think even a lot of us live in fear that there's nothing we can do.
Yeah. And, and I think they're afraid to ask that question too, because, a lot of times they'll say, oh, it's about the same. But then when they fill out the questionnaire, their questionnaires their numbers have improved. And it's like, okay, it's more than about the same because you're answering this differently. And it can help us say, oh, look, you're doing great. We're seeing progress here. we're following our treatment plan, and you can show them the evidence that no, it's changing. So I like
right?
that
Don't
part.
I think you and I agree, but don't we owe that as a minimum to our patients to actually track the progress of our treatment outcome?
Yes, I do. And, not only
Right?
tinnitus, yeah, I think that applies across the board. And, there's so many different ways that we can track it. The questionnaires are one. And, for those that I find most don't have to have a tinnitus generator set up, but when they do, one of the first things I look at is their data logging. And I look to see how long have they used that tinnitus generator program versus their standard hearing. And I do separate the two. I never, ever put it on an automatic program because part
Never.
of personal issues with tinnitus is control. They feel they have no
Yeah.
control. And they want that option of, oh, my tinnitus is bad today. Okay, I'm going to use that generator that they set up for me. But I also encourage them, don't use it, use it as needed. You don't always have to turn it on as soon as you get out of bed and put your devices in. Use your hearing device, and then as you need it, use that generator. And I like to see, and for most patients, what I see over time is in the beginning that they use the generator a lot. And then slowly the data logging changes where they're switching just to the hearing device. And that's our goal, is to get them
Yeah,
so they aren't relying on
I
that.
feel like because I've learned so much from you and from each patient, I sometimes almost chuckle when people ask me, yet they ask it all the time, right? Hearing healthcare providers ask me all the time, what about those tinnitus programs? And I think you just gave the best advice possible, which is number one, they need control. Number two, the goal is to actually wean them off of that, right? So set them up separately. This is what I heard you say. Tell me if I'm right.
Yes.
Set them up separately, give them access to the program under the guise of use it when you need it. It's not a 24/7 thing. It's not something that you always need or want on. What we're attempting to do is actually reduce the amount of noise over time. And I love, again, because you're quantifying it, right? Because you are actively data logging. You're seeing, like if I had a chart, you're seeing, maybe 3 hours of use week 1 per day. But over time, as you get out to month 3, month 6, you're seeing maybe 5 minutes a day, maybe 0, probably most days.
Yeah. And it is good when you see that. It lets me know, okay, we're on the right track. They're headed in the right direction. They understand their own tinnitus. They know when to use that program, when not to use that program. And it's all, it's an adaptation process, just like we use in our day-to-day hearing setup. So definitely another
so
thing.
here's go ahead. No, well, no, in fairness to the listener, here, I want to actually define this. Number one, we qualify. Number two, we quantify the experience. You went to number 4, which is tracking progress. And well, what is the treatment protocol and how do we track progress, which is looking at the data logs, setting up the alternative program, and doing the THI or whatever form you used on day 1, doing that over time. I want to talk specifically about step 3, which is what else are you doing, if anything, in terms of quantifying the tinnitus for your patients? And what I mean by that is there are still a lot of people out there that say tinnitus matching, volume matching, this stuff's important. And I would love to get your take on it.
My take is probably not the popular opinion.
I think we're going to be on the same page, but that's okay. I think people need to hear it, and then they need to understand why. So tell me your thoughts, and then tell me why.
Okay, tinnitus matching to me is you're marking a, sometimes, not always, you can mark a specific frequency. What I found being in the field 12 years is usually tinnitus falls where your greatest loss is. So we already kind of looking at that when we see their OAEs or audiogram, we can see pretty much or estimate where that tinnitus is going to be. And I'm one that I do my setups very differently. And I don't think you can find it anywhere in the textbooks or anything like that. This is just something I've learned in the field and with my mentor that I used to be on a tinnitus team with, is we if this is our tinnitus, a lot of people come up here and try and match that tinnitus, or they'll go above it. They want to drown out that tinnitus. That's the worst thing you can do, because when you're doing this, the tinnitus is going to be aggravated. It's going to come up, and then you bring it up. And it's just this little war where I believe this is your tinnitus. We're coming in low, gently in the background, just to create a competing sound, but we're not overpowering that tinnitus. I found that it creates a tug of war, and tinnitus will win. So I come in very low, and as I want it gently in the background, that generator.
See, Paula, you're just a much nicer person than I am, because when somebody asks me, I just use the simple phrase, it's a waste of time. So you just said it much nicer. And I like, because I just cut to the chase, right? But I appreciate you. I think what you actually did was you actually described, when I say waste of time, I think you described exactly what I really mean and sort of really elaborate on the why, which is, right, it doesn't, in my opinion, it doesn't seem to do anything for treatment, right? Like you just said, you're not going to match it and then like try to turn on a tinnitus generator that's in that same region at the same volume. The tinnitus will win. I love what you just said. And you're also right. I almost wanted to interrupt you and say, duh, like, yeah, wherever the hearing loss is, the tinnitus is, right? Which is why, and you've heard me say this before, tinnitus is hearing loss, and hearing loss is tinnitus. And we have to stop separating the two. We have to, like, nothing drives me more crazy than when somebody says to me, I have this patient who, has good hearing, but they have tinnitus. No, they don't, right? Look, unless it's the jaw or it's heart related, I understand that 1% of the time the tinnitus comes from outside the auditory system. But I'm gonna place my bets on the 99% of the time, and that it's the result of damage to the auditory system, right? You know this. You can lose 80% of your neurons that connect the ear to brain and still have a normal audiogram, right? So yeah. There's no such thing as good hearing. The audiogram is a piece of junk. It doesn't define whether or not a person has damage to their ear. And it's that damage that sets off all these, it sets the neural system haywire, right? It just sets it ablaze. And now you've just got this ringing.
Yeah, absolutely. And that, just yesterday, when we're doing the audiogram 125 to 8,000, the patient indicated, no hearing loss. Well, guess what? Thanks to you and the training that I received, I did extended high frequencies. And of course, that's where, the hearing loss showed up, was in those extended high frequencies. Mild tinnitus, maybe once a month, doesn't last very long, but those are all keys that, hey, we know auditory nerve damage has occurred. We do have hearing loss in the extended high frequencies. It's there. It's just a matter of when it's going to show up on your traditional audiogram.
I love that. I like that. I like that. The traditional. I'd say it. I usually call it junk, but traditional is fine. But look, so you just got at what I really was trying to dig into. Number one, which is, number 3 on our list. We qualify, we quantify, and now we want to actually diagnose, right? Again, I know IHS wants to slap my hand when I say the word diagnose, but that is ultimately what we're doing. We're trying to find the source of the tinnitus, and you just helped really bring out that conversation, because people ask this all the time. Look, you want a tinnitus match? Go ahead, right? I'm not here to tell you don't do it. I don't understand the point. And to me, it doesn't necessarily do anything. But what can we do, right? So extended high frequency testing.
Absolutely.
And otoacoustic emissions, right? So those are much better tests to determine the function of the cochlea. And when there's damage in the cochlea, whether discovered by otoacoustic emissions or extended high frequency testing, you've now confirmed that is the source of the tinnitus. That is your job as a diagnostician, is to uncover the source of the tinnitus, right? That is step 3 of the tinnitus patient. You agree?
I would agree. And, the OAEs showed me, in those upper high frequencies, that's why it indicated change. And, I definitely, when tinnitus is being said, extended high frequency testing, I think, is a must. It's, and if you want a true picture of what's happening, then, like I say, if I would have stopped at 8, it wouldn't have indicated anything. And
yeah, like I wish I had that DeLorean, right? So I could go back in time and say, who the hell determined that the second half of the cochlea was not important, right? Because that's just dumb. And like, who determined that 25 dB was the mark of normal hearing when the data from Fletcher, 1922, 100 years ago, told us -7 to +13 is the normal range, right? Like, you get 25 just ain't cutting it. But anyways, I mean, we can't fix history, but we can certainly learn from it. Let me ask you.
You're definitely making your mark on getting that known, though. How many people know about that -7 to 13 now? Because I've heard you say it in many different discussions, and it's changed the way I've said things for sure.
Sure. Oh, I don't care what the topic is. I'm bringing up the -7 to 13. I always figure out a way to get that in there because not enough people know. Now, let me ask you something that's a little, I don't want to say controversial, but let's just say it's new, right? So in the process of uncovering the source of the tinnitus, we talked about otoacoustic emissions. We talk about extended high frequency testing. What are your thoughts on the role of cognitive screenings and how it applies here? What are you thinking?
Definitely, here at Intermountain, we use the CogniView at every evaluation, every annual testing. And I love to see the comparison of before treatment and after treatment, because we do see differences. So to me, it just quantifies that, what we're doing is helping, because I've seen those changes in my patients where their memory was, for example, someone came in, they were already a device user, but they weren't wearing the devices. They were just occasionally wearing them when they went out and things like that. So I had a very, heart-to-heart talk that, you need to be wearing these every day. And I want you to do this, and we're going to bring it back in, and we're going to look at your scores. And when they saw their score, I believe like their memory was 32 and it went up to 78 just by wearing their devices every day. That told them more than, any of my lectures to them could. It's like, look, you see the difference. Their family noticed the difference. So it's more than just quantifying it, seeing the impact on their day-to-day living.
Paul, I love what you just said, because you're actually the second person that I've interviewed recently who used that word lecture to my patients. Because we do, right? We want to educate them. But what's so great about being in hearing healthcare today is that we can reduce the amount of lecturing we do, and because we have more tools that allow us to more quantify and prove to our patients, right? Like, we don't have to just talk about the connections of hearing loss and cognitive decline. We have a way to do cognitive screening. We don't have to just rely on the audiogram, because we have otoacoustic emissions. We have so many tools in our tool belt that help us be better at quantifying, which allows us to lecture less, because now the patient's just like, I get it, right? You hit them over the head with the test results. There's no more arguing. There's no more convincing patients of why it's so important. Now it's just like, here's your test result. You're an idiot if you don't start treatment. Again, my words, not yours.
Definitely, I'm for that screening, because with any medical condition, detect it early, treat it early. If we stay on top of that, by completing that annual and include that in our annual testing, it's helping us get them their best hearing potential and their cognitive health at the same time.
And look, here's how I think about it. Give me your thoughts. Because look, if the patient has damage from their ear to their brain, right? Even though I think that ear to brain tagline is a little wonky and a little goofy, but fine. If there are issues with the ear to brain connection, and we're finding it with otoacoustic emissions, we're finding it with extended high frequency, most of our patients just show it right there on the traditional audiogram, as you said. These, especially the ones with tinnitus, right? I mean, tinnitus is the smack you in the face. There's something wrong with the central nervous system. That's what tinnitus is. It is a neural consequence of hearing loss. It's telling you there's something wrong in the central, and it's not just the central auditory pathway, because we know it impacts the limbic system, the memory system. That's why some patients are so emotionally affected by it, because of the way it interacts with the limbic system. Doesn't it just make sense to do a cognitive screening, which looks at our ability to process? It looks at how our central nervous system processes all these inputs. I mean, it just makes sense.
Absolutely. I think it, and that's why we do it at our evaluation and every annual and as needed. Sometimes our patients come in for just those clean and check or a service call, and we notice, when you see these patients for years, you notice the changes in them. And, it doesn't have to be that specific appointment. I think if it's there and we see that change, schedule it or do it that day, and find out, especially if it's noticeable to us, it's noticeable to family and others. So definitely.
That's great. That's great. So all right. So here's what I got. Here's what I think the takeaways are from this interview here, right? We've got to qualify our patients' tinnitus. For those that meet a certain criteria, right? And I like to say, look, if people are answering 5 or higher on the qualifier, right? Rate how it's impacting their life. I think that's a great number to say, okay, if you're 5 or higher, let's quantify the impact of the tinnitus. Like, let's get to step 2 and do an actual evidence-based survey like the THI, tinnitus primary function. We talked about uncovering the source, which includes doing more testing, using more of the tools in our toolbox. That includes speech and noise testing, extended high frequency, cognitive screenings with CogniView, otoacoustic emissions. And then we talked about actually how to set the device, how to set the technology, which I love your approach to, which is let's give them the power, but let's teach them over time. The goal is to reduce usage of the tinnitus program. Am I summarizing good so far?
Yeah. Yep.
All right, great.
Yep.
Now I want to get to what you touched upon earlier, which was the pre and post survey, right? So I've seen your data. I have seen your patients that have gone from level 5 catastrophic on the THI, scores near 100. It's like destroying their life, to scores down in the 50s, getting down to the 20s, and just completely restoring their life. And I think anybody watching or listening says, okay, that's easy. That's great. I'm going to start doing this. But I want to challenge you, Paula, because this is going to happen. What about the patient whose score does not significantly change? What do you like? Tell me about that case, because I know you've had some cases like this. And for those that are scared, say, oh, I don't want to do a pre and post, because what if the score doesn't change? Now I'm up shit's creek and the patient's going to hate me, which isn't true.
There are some that, when they fill out that THI, we may see that score only drop 1 or 2. And that's where I think it's our job to ask a little bit more questions. I had a specific patient that was a vet that scored very, very, very high. It was interfering with his daily living. His communication with his family was almost nil. And when he came back in, the THI, it dropped, I want to say maybe like 4 or 6 points. But
which is not significant. It doesn't effectively it didn't change. I'm going to be a scientist, and I'm going to say significantly it didn't change, which okay, it's going to happen. But tell me more about this vet. What happened? Did he reject treatment? Did he say forget it? Like what was his?
Oh no, he loved his devices. He was wearing them every day. Previously, he had 2 or 3 sets from the VA. They did nothing for him, and his life changed. Even though his number wasn't significantly changed on the THI, the impact, the day-to-day, he started having conversations with his son, which was amazing, because at that point he was pretty much isolated because of his tinnitus. So for him being able to talk to his son, and his son coming up, it wasn't even him approaching his son. The son approached him. He's like, Dad, you're in such a better mood. What's happening? What's changing? And to have that conversation where he actually was able to talk to his son about his tinnitus. And he even played like a demo sound on his phone and said, this is what I hear every day. And I mean, it was a tearful conversation between the two. And it impacted his family, and for his family to notice the change, and that he was happier, and that he was out and going and doing, like, he lived 4 hours away from me, but he wanted to get the help. He was passing through St. George, going to Vegas, stopped in, just to pick up supplies. And, when he met me, there's no way he would have gone to Vegas in that type of super noisy environment and was going to go clubbing and things like that. So it definitely left, a big impact.
So I love that, right? I love that even in a scenario where, and by the way, this was I believe the data you're reporting where it didn't change. It's not like it hasn't even been years, right? Because the impact on rewiring the central nervous system to slow down or reduce the tinnitus can take 18 months, right? You're talking about just in those beginning stages where maybe the THI score did not significantly change, but you absolutely unequivocally changed this patient's quality of life. And isn't that what it's all about?
Yes. And his perception and being able to live again. How many times do we hear our patients that just have hearing loss that you gave me my life back? And with tinnitus patients, they not only usually have the hearing loss, but they have that auditory nerve damage and that tinnitus there. And tinnitus can even affect an audiogram. How many times have we seen, they're like, man, these devices are like too loud. And you go back in because their tinnitus was so roaring that day, you didn't get an adequate audiogram, and I think that's something we always have to keep our eye on too.
So this has been a tremendous conversation. I think it's going to help a lot of people because without naming names, I was at a conference recently and it happened again where a provider said to me, oh man, the tinnitus patient, keep them away. I want other people to deal with that. That's not something we do in our private practice. And I just thought, really? Like, are you still in that mindset? Like, we can't turn these people away. Do a simple Google search. It'll tell you 50 million people are suffering with tinnitus. Over 26 to 27 million of them consider it bothersome. 2 to 5 million consider it debilitating, right? And there's nobody better. There's nobody better. There's never been more proof than there is today. Recommended by the American Academy of Otolaryngology Head and Neck Surgery that the number one form of effective treatment is being seen by a hearing healthcare provider and being prescribed hearing technology when necessary.
Yep, absolutely. And it makes me sad to hear that there's still people out there separating tinnitus patients. It's like,
that's okay.
Hopping back to the 1990s or early 2000s, it's like, all the manufacturers are on board now. Tinnitus is one of the most researched words on the internet. And you're only hurting yourself and your practice if you don't address it.
And I hope what we've done today is those naysayers, those doubters, or even those people that are just a little hesitant, I hope we've really helped to lay out the process of what it looks like and how easy it can be to work with tinnitus patients and how easy it can be to have such a significant and profound impact on their lives. So thank you so much for taking the time today. I know you're at the office. I know you took time in between patients. Perhaps I even took your lunch hour, but thank you so much for being here and for sharing your story.
Thank you. I'm passionate about tinnitus. I love to help people. And, happy to be here talking about it with you.
Yeah, great. Thank you so much, Paula. Have a great day.
Thanks. You too. Bye.